and then you do some of the documentation during your sessions. So we recommend, and what seems to work out really well, is to say, well, listen, I understand you might have some concerns about it. The finding is that the clients we work with really like it. How about we do it just for the next 2 or 3 sessions, and then we can revisit whether this is something that works for you. And if you do that, you can get the same conversion rates that we showed earlier, where you can get 85+% of people liking it, and most of the remainder saying, okay, if you want to do it, fine, if not, fine. People who really rail against it, let's not worry about them for now. Sometimes what happens is people know other people that are here, work with the other people, let them get word around that this is something that's helpful, so there's no sense with existing clients forcing someone, but usually we can get them to be willing to try it a couple times and then make a decision about whether it's helpful. With new people, it's really good to start right away. It's more just like, here's our process, and before you know what they're doing it, because we didn't give an option. We did have, interestingly, we had early on, probably 7 years ago, we were training an organization and they had a peer group. And the peer group was really, at that time, focused on, we think we should explain it to the clients and get their consent to do it. So I said, if that's what you want to do, that's fine. But when you're going to use a new evidence-based practice like motivational interviewing or DBT, we don't ask people's consent for whether or not we can use it. We just apply the best strategy. So when they did it initially, they only had about 45% of the peers said they wanted to do it. Then they watched as the rest of the organization went on, and they watched as the 45% they worked with did it, and they changed their minds about that. Because they realized when you ask someone, do you want to volunteer for something, in mental health like the military, it's best not to volunteer for anything. And they really didn't know what it was, so it's hard for them to really judge that. So we just recommend encouraging people to at least try it, and then it takes on a life of its own after that. I think we pretty much covered what if I have a different perspective. So there are things that you need to document, and for the most part, as long as the clients have the ability to put their perspective in, disagree, they're okay with that. It solves a whole host of problems. It says, we don't want to come to consensus about what's a statement that we can make together necessarily, although there is a place for that in one of these later questions. It's more, listen, this is, I've got to give my honest observations, I've got to do honest assessments of progress, but I'm more than willing to include in here your perspective of how things are going and what you want to do. And also, like if I make recommendations and you don't understand them or think they'll work, let's come to terms with that so we can figure out why it's not going to work for you or not put recommendations in just to put them in. Yes?
So when you're working with someone maybe for order, and you say that, and you have totally different opinions about what happened, and I agree. So the group she may have disrupted the group, stormed out of the group. There's a lot of things that I can say to her. You do this, and this. But the response is, you write that down, and I'm going to go back to jail. And you know that, and then it starts this huge blow up that may.
Right. Well, that's an example that sort of goes into this next one, but let's talk about that. Objective things, people have trouble, like, I don't think in your mission statement anywhere it says, we're here to provide cover for you for the court. or we're here to provide cover so you can collect benefits, right? But we do a lot of that. So I think that you can start off by gently saying during the group, and I first have to explain how we do it in group. But during the group, the client left, got upset at something and left the group for a while and then returned. That doesn't sound as bad as she got angry and stormed out. But what you can do then is have a conversation with her and say, what do we need to do so that that doesn't happen? Because I'm obligated to report what really happens. And if she, and let's say this is a person who really has a lot of problems with emotional regulation, and it's not just that she's getting up and going out because she's a bad, she's defiant. What we can do is say, I can put that in the record, that you're working on it, you come to group, you're making the effort to attend, but you're still getting up and leaving the group when you get angry. And hopefully for a person like that, someone in her treatment plan is someone working with her on the emotional regulation part. Because that's what's maybe having her, unlike other people, who feel the need to get up and storm out as opposed to just voice her opinion. So that may be the reason she's in trouble with the law to begin with, isn't so much, maybe may have a lot to do with her emotional, just her ability to, manage her emotions. So those things do happen in groups, so we describe them, but it doesn't mean we're labeling the person or not even necessarily saying they're uncooperative. Maybe while she was there, she was active in voicing her opinion, that should be in the note too, and then she got upset and felt the need to have to leave the group. But we're not going to, in substance abuse, one of the rules is I'm not going to lie to you and I'm not going to lie for you. So I'm going to be honest with you, but it doesn't mean I'm going to lie for you to people when, it's a clinical concern. Sometimes people will do things and we have to ask ourselves, does this really need to be in the note? Or is this something we should handle first personally with the person? And then say, this is the kind of thing I'm going to have to document, but I just want you to know it. And again, hopefully someone's getting her help around her need to do that.
She's one that would be tempted to label to that 7%. And because that wrap up that should be 10 minutes will turn into 45.
Well, in group, I'll tell you how we do that. So is she getting individual work as well?
No, just group, it's peer support.
Oh, okay. Because it sounds like this is a person who also needs to give you some attention outside of just a group modality.
Well, she's mental health worker, she also has a leg on
Okay.
so there's a lot.
Because it's hard with the group to leave one person out. It's a process, so it's hard to, it's not like we're meeting individually with everyone after group and doing their note. We're doing it as part of the group process. I'll explain what I mean by that. What if a client says they don't want to record something? So does this ever happen now? Do clients ever say, I want to tell you something, I don't want you to put it in my record? So it's not really a collaborative documentation question because you do something about that now. You have to make decisions, right? About if a client says, listen, I'm telling you something, don't put it in my record. What do you do now? I had one clinician said, I sort of distract them, get away from the question, never answer them, and then I put it in the record. Probably an effective approach, but I don't know how ethical it is. And everybody else was sort of nodding like, yeah, that sounds like so there's a couple of things there with that. One is, I can give you an example from my work in the dual disorder program. Regularly, when people sort of were moving from pre-contemplative to contemplative, they would at some point, we would do urine screens, we do drug tests. At some point, someone will come in and say, listen, I slipped last week. They're voluntarily telling me this. So to me, this is great news. But they're saying, but don't put it in my record because it'll get back to my probation office. So what I say is, listen, I can't not say it, but to me, this is the best news we've had since you're here. Let's write the note up that way. Say that it wasn't a screen, we didn't catch you doing it. For the first time ever you voluntarily talked about it, which really indicates you're moving to a more, getting ready to an action kind of stage. And I'll go to bat for you with your probation officer. Because I knew the probation officers at that point. They know that relapse is part of recovery. And so, but I wasn't going to lie and not put it in there. I was going to do it that way. Sometimes we just have to modify the way we say it. I had I didn't have a client, but we talked about a client a couple of weeks ago in one of these trainings. And they had already done, some people had already done collaborative, and it was a person who's, sexually inappropriate behavior in public. So it hadn't been happening for a while, and what the guy wanted to write was, the client, masturbated in a public park somewhere. So the client said, I really don't want that in the record. So they sort of negotiated and said that he acted in an inappropriate manner sexually in the park. The client was actually okay with that. He just really didn't like the description of what he was actually doing in that case. But they explained to him, that we do want to hear these things, we're trying to help you, but we've got to indicate it. We can't just pretend it didn't happen. When we have the option to write in our offices in private, we tend to put too many of the gory details about things in the record that don't even necessarily need to be in the record. So if someone got involved in some sort of affair or incident and they're feeling terribly guilty about it, and our main focus is to help them address the guilt. This may be something that happened a while ago. We don't always have to describe the details of what happened. We can just say the person got involved in an incident that they feel terribly guilty about, they don't know how to share it with people. Is there any clinical value in putting the gory details in there in terms of treatment, what our approach is going to be, or any of that? If it is important and it is key, then what we've got to do is put it in and explain why. And the worry that people have is, well, if clients are going to know that I'm writing things in that they're asking me not to put in, might they stop telling me some things? And it's a risk you're on, but to me it's an ethical plus in terms of, because if they're upset that you're putting things in the record, what it means is they didn't really understand the nature of what you were putting in the record when they didn't know about it. In other words, they wouldn't have signed a release saying you could share this if they knew you were writing that kind of thing. A lot of clients just think that you're right, I met on this date, we started at this time, we ended at this time, here's your progress. They don't know that we're doing this stuff. I have to tell you, with these 9 years of experience just in living training like this, I couldn't count on one hand the number of times people feel that clients have closed up as a result of this. So I just think we have to be honest with people, use discretion in terms of what we have to write. Sometimes we realize, this doesn't have to go in the note at all. I put it in, like the editorial, like I saw before about CareLogic is gone. I've seen in notes editorials about the reason such and such is because my supervisor does what it, there's also editorializing about staff, about all sorts of stuff. They had to get it out somewhere, so they put it in John Smith's record. So does anybody else have examples of that? Things that the client asks you not to put in the record. What do you do about it now?
You get a lot with adolescents. They don't want their parents to know something you're
Right.
talking about. We got to work with the ethics of confidentiality with teens,
Yep.
and that's scary.
Right. So in different instances, you make different decisions about how to handle that?
Yeah, I mean, it depends on the age of the child and what the parent already knows and what the agreement was in the beginning.
Right.
About what the parents said they were going to want to know as we move forward.
Right.
So.
And that's an important thing you just said, is because that's one of my answers, is to make it really clear what the agreement is in terms of parents have the legal right to know what's in the record, but if they want us to help their son or daughter, are they willing to forgo some of that and trust that we will let them know if we think that their child is in danger. We let the child know that. So if we think you're in danger, we got to do what we can do to keep you safe. But other than that, we just let the parents trust that the child will know, the adolescent will know what's in the record, but the parents won't ask to see the record. Now, can we prevent them from legally doing that? But we can get sort of a written agreement down that could make it sort of drag out the process of them seeing the record. Because we do have recourse. Clients do have a right to see their record, but we have recourse in the sense that it's something in the record that we think would endanger or traumatize the person. We can just share parts of the record that we think are most relevant. I don't like doing that, and it's an unusual case, but if we got an agreement from the parent and the child is acting according to that agreement and telling us things, I could make the case that this violation now, the parent wants to start reading the record, could damage the client and their trust in the system and that stuff, and I could certainly drag it out for long enough, hopefully, be able to do some good for that. How do I document something I don't want the client to see? So I'm very clear, first of all, with clients that what we do together, what we discuss together, we're going to document together. So any work we do together, we're going to document together. I personally I don't really remember a specific case where I had to do this, but people have given me examples of good cases. So it's early in treatment, we have a suspicion about trauma, about something. We don't think the person's ready to hear that yet, and yet for some reason we do think it's important enough to let other team members know beyond just verbally letting them know. So what you can do is document a regular session with the client with them, because we didn't say anything about that, obviously, so we document everything we spoke about. And then you can do a non-billable informational note in the record saying, I just have this concern, and want make team members aware of X, Y, or Z. Before you do that, I would do some rule outs. Is this something that's really important to be in the written record at this point? Which one? If it is, okay, it passes that test. And is this really something I can in some way approach with the client? And if the answer to that is really no, and you feel that it's important to be there, what we have to hope is that the client doesn't get to read that in the record and fully understand we did that in their best interest. And that's the best we can do with that. But people really get good at, there are all sorts of classes of things. I'll read note after note where it's like client appeared for session disheveled with poor body odor. And then they write about whatever. And then the next note, client appeared disheveled with poor body odor, and meanwhile they're talking about other things. And they say, well, I can't talk, I can't write this in front of the client, that they have poor body odor. So, I said I could see in the first session or two, we haven't built rapport, probably not a good rapport building strategy to say, by the way you smell. And at that point, it's probably not terribly important that we put it in at all. But at some point, if we're not the one talking to clients about that, who's going to? So if it's important enough to put in there, it's important enough to have a conversation about, because a lot of clients don't know it, actually. They may have personal goals, like they want more friends, they want a girlfriend, they want a job. They need to understand the obstacles that imposes. And it's also a good sign of deterioration. It's a good self-sign and the staff sign that things are starting to go wrong because you're starting to not take care of yourself again. So things like that, I think we should just talk to them about. Some staff are a little chicken, and they'll, someone will come in and they need to report it to Child Protective Services. They've reached that point where as a mandatory reporter, I have to report it. But they don't tell the client about it, they just report it to CPS, and CPS shows up on their doorstep one day. And just like an emergency room, where if you bring your child in the third time with a broken leg and fell down the stairs, story's getting old, they don't tell you, accuse you of anything. They say, we're not accusing you of anything, but when we reach a certain pattern, we're obligated to investigate it, for your child's safety, so we're going to be reporting this. And we should do the same thing. We need to be upfront and let them know we're going to report it, why we have to, that we're not accusing them of anything, but it's the child we're concerned about, so that's what we have to do. And some people aren't going to take well to that. Also, just discussing confidentiality beyond that paperwork they signed on day one. They're not paying any attention on day one. They're signing a whole lot of things. As soon as we start to develop any sort of relationship with them, we really need to go over that again. What is really confidential, what's not confidential, so that they actually understand, especially going to do. Because right now, the issues don't come up because you're writing it without them knowing it. And again, those are the cases where people would get really upset if they saw what you were writing, as opposed to what you were talking to them about. So with collaborative, it's going to be pretty much all up front. What if clients too cognitively impaired to participate? So we'll get this sometimes, where they'll say, we have some clients that are so functionally impaired and cognitively impaired, they're not going to understand this summary process of what we did. My issue is if they're too cognitively impaired to understand a summary of what we did, they were probably too cognitively impaired to understand what we did. And so if they can't understand a summary, there's another Medicaid requirement is they have to have the capacity to benefit from treatment. Okay, we can't guarantee they're going to benefit, but they have to have the capacity. So if we're doing some sort of verbal work with someone who doesn't have the cognitive ability to benefit from that, we can't do that well with them. And if we do the work with them, then they should be able to look. And in fact, what people will say is, I've cut down the verbal parts or the skill training parts and spending more than that 5 to 7 minutes going over what we did using a different medium like the writing to increase or optimize the chances that they are going to take something away that's useful for us. So that's another thought. And that's the only questions that I've got up here. So I have to imagine that you guys have some individuals in mind, cases in mind, need more clarification about some of what I talked about already. Because again, I want you to think like you got to start Monday. Okay, so in doing that, do you have problems with anything I said all day, number one, confusion about that, or questions about these sort of where the rubber hits the road? Because we usually spend a fair amount of time on this part. As people start to think about individuals that they have. There are cases where certain individuals have a very focused, for example, delusion relating to electronic equipment. So they'll say, when I see this certain client, I have to shut off the computers altogether. So how am I going to do this? Right? So knowing what you know about collaborative documentation now, that was not just a way to save time. What would you do? Well, the computer system's down today. Right? The, what is it called? The care logic is down. So what do you do those days? You can use Microsoft Word, or you can just have a paper template. And what you say is, we still want to take down, make sure you know what's going to go into your record. we want you to get your input and stuff, and when the computer system comes back up, this is what I'm going to put in the record. So again, you can use Word templates, for example, if you're in the community and you're on connectivity. You can use paper templates. Some I don't know if you've got the situation, but there's some areas where people are very uncomfortable bringing anything of value to certain neighborhoods. Like I said, if I brought a laptop and brought a guitar in my back, what they do is for those clients, they use the paper form. You know, the philosophy is this isn't just about saving. It does save a lot of time, it creates capacity, it makes my work life much better. But the more important part is that people are getting to know what's in their treatment plan. It is person-centered, it's helping them to remember and understand things. So we're not going to just do it when it's convenient for us. If the system's down today, we're going to find plan B to do it. And it won't save us as much time that day, but it keeps the continuity of the process. And the message we're sending the client is, we're going to do this because it's important for you, except when it's not convenient for me. You know, so we're consistent with it, and we do it regardless.
Does it go without saying that client outcomes in terms of goals and problems improve with this golden thread?
Well, with the golden threads, that's the concept. Certainly treat to target does. What research does show is that if you don't have a real target, if you're doing sort of process treatment, because you know, psychotherapy outcomes have improved in almost 2 decades overall. What has improved is the use of evidence-based practices and target-based treatment. So to the extent that this is helping us actually target things that matter to the client and sticking with a focus on those, using interventions if they don't work, learning other interventions, you know, learning other ways to help make these things happen. It's not going to happen 100% of the time, but it's certainly going to improve. The research we're talking about with NYU is getting at what you're talking about. In other words, this has now reached the national level of discussion where federal government is willing to dump some money into, let's find out some of the clinical outcomes, not just the time savings outcomes. We get good client response data, they know about that. We've got that one study that showed increased improvements in medication adherence. But that's a process thing. That's good, we know it's good, but it's not necessarily showing ultimately that we've done a better job than most of the outcomes. One of the problems with demonstrating outcomes is that we don't measure them now. You know? So I think it would be great if you look at me, I got 3 charts and 3 of them with depression and anxiety. A very common problem. Wouldn't it be great if Advantage could say, here's our track record of dealing with folks with depression. 80% of people have an 80% improvement on PHQ-9, which is a nationally accepted measure. Nobody else is going to say we do better because they don't measure it. And if they do and they get 90, what happens is you guys start trying to figure out what they did and outcomes get better. So they do it in hospitals, you know, they do it for heart surgery, they do it for, in Florida now, when you approach an area that's got hospitals, emergency rooms, there's a big road sign that lists those hospitals and lists the current wait times in the emergency rooms. So when they first did it, it was 17 minutes, 20 minutes, a half hour. Now it's 2-3 minutes. Because they all know that there's this road sign out there, and you're going to go to one hospital or the other. They want to be the ones that you go to. So we should be able to do the same thing, but where we have to start is at the patient level. If we don't even know what the outcomes are for you that I'm working with, how are we going to aggregate that to say, here's how we do with folks with depression? You know, you got to settle on measures and be able to, you know, because the movement is towards pay for value, right? Not pay for per session, not pay per, you know, capitated rates or bundle rates where we pay per person, but starting to pay people in proportion to the value. So the work that's being done is developing the measures that you use for that. And we should be at the table for that, because we're the ones that do it. So what the true answer right now is I can't say with collaborative documentation produces significantly faster achievement of objectives, because I'm having just have trouble finding organizations that actually measure the achievement of objectives, you know, in the first place. So that's where we're moving to now in terms of the research we're going to do. We're going to put the measures in place and get organizations to, we'll probably be randomly training some people, not other people, as we did in the other projects. We're working on specific populations and seeing which way works better in terms of achievement of measurable outcomes. Other questions, scenarios? Okay, so let me talk about group for a minute. There's a number of various places here in the group. So there's a couple of parameters that make this easy to do or hard to do. Now, for me, you can do it if you want to do it, but there's things that make it easier. So the first thing I think you have in place, so your electronic record, if you run groups, is a rostered group system. So if it's my Thursday afternoon anger management group, it knows to pull up the 12 people, whoever were assigned to that group. Is that correct? Okay. When you pull up one of their progress notes and in the first record put in group intervention part, the part that's very similar, does that automatically populate into the other folks that were there that day?
Yeah.
Right. So those are two key things that your electronic record does that a lot of other people don't have that makes this whole thing a lot easier. Do you run any evidence-based groups or curriculum-based groups?
Yeah.
Okay. Does anyone run just general process groups? We have a few general process groups. The hardest place to do any of this, including compliance, medical necessity, all of this is in process groups because you need a very skilled person to make sure over time that each of those groups is actually impacting the different kinds of goals and objectives for people in the group. So you have to know what their goals and objectives. They have to be in your group for a reason. It can't be because you had a vacancy or somebody wants to be in the group, right? To bill for that group, they have to be there because it's a potential intervention that can help make an objective happen, right? So now you've got people with all different kinds of goals and objectives, as opposed to an anger management group where we could safely say everybody in the group's got some sort of impulse control or anger behavior kind of objectives in there. So it's pretty easy to deal with that. So let's talk first about the evidence-based or the curriculum-based kinds of groups. The next parameter is how long is the group, duration-wise on a given day, and how many people are in it. Okay? So if we have a 1-hour group and we've got 8 folks in it that actually show up on any given day, good. If we have a 90-minute group that's got up to 12, 13, they may have 14 assigned, but on any given day it's going to be 12, 13, okay. If you've got 20 people in a group and it's an hour and a half, it's not going to work. I work with substance abuse organizations that have 1-hour groups with 25 people in it. First of all, 25 people in a 1-hour group, that's not a group, it's a bus trip. Right? That's not a group. That can be an educational session where we're didactically teaching people material, just like a class, and the goal is that they learn that material, but it's not good for anything that has to do with discussion. The idea that there's discussing going on is 1 hour with 20 people in it is just not a group. No one would advise that that's a sensible group. So here's so first I'm going to tell you the process that we use, and then I'll tell you what you might be able to do about those 20 people in a group, 18 people in a group, 25 people in a group. The process is you look at the group. So let's say we've got the 8 of you here. You've all showed up today. I've got a 1-hour group. I multiply the 8 times 2 minutes. I need 16 minutes at the end of this group to change the group process to a different process. I let the clients know, depending on the group, here's the questions we're going to have each of you respond to at the end of the group. We're going to do a checkout, okay, where we're not having crosstalk, but everyone's going to get an opportunity to express their opinions about the group. It might be, what did you think was most important about the group? How is this helping you with your goals and objectives? Which means they got to know what their goals and objectives are related to the group, right? Other groups, DBT groups, they might ask different kinds of questions. They might say, based on this kind of the nature of our group, we'd also want you to answer this specific question because it sort of fits in with that evidence-based practice. So you can decide, or you can look at your form and say, what do I have to document? And make sure that the questions answer that. Initially, they might actually hand out a piece of paper that's got the questions on it and say, as we're going through group today, you might want to take some notes because we're going to ask you to spend about 90 seconds just saying, for example, what did you get out of the group today and how did, is this helping you with your goals and objectives or is it? Or where do you stand on your goals and objectives? So then you have your group, you're hitting that meeting 16 minutes, you bring up the computer. There's an even better way to do this, what I'll describe the normal way. And you bring up the first client's chart, put in start time, end time, that stuff, and say, okay, first I want to just summarize what we did today. So today we had a discussion about positive and negative thinking and how this can impact blah, 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 blah. And you type that in. Now that's done for all 8 clients, right? Because once you type it in one, it automatically populates the others. Then you say, okay, you go first. What did, answer those questions. What did you get out of group today? How's this helping with your goals and objectives? You got their chart up there, you're listening to them, and saying, okay, so if I heard you right, XYZ response, and here's how you think you're doing with your goals and objectives. But you can also, up in the body of that, Say also, you would make some good comments in group today to start a side discussion about something. So you can personalize it that way. Then you say, okay, you bring up the next note, you start going. So while you're starting to talk, I'm listening, getting ready to summarize their personal stuff. We want to control it so that we're not starting group over again. You know, we're not having you respond to your comments and then you chime in and agree with him or with her. We say those kind of things we can talk about next time. This is what we call eye time, which is time for everybody to have a chance without interruption to let people know what they thought. So first of all, this is good because we run a lot of groups where a couple of you never said a word during the whole group. And then I'm responsible to go back and somehow individualize this note for you when I never got to hear from you. That doesn't mean you didn't get a lot out of the group. You just might be introverted, polite, I didn't want to interrupt people, or you're a good listener. So what people say is I'm all of a sudden finding out that some of the people that don't say anything are actually getting a lot out of the group. If you run a lot of groups, this is a lifesaver. Okay, if you run 3 groups a day, and they've got 10 people in them, you know, you start looking at that over the week, it's an enormous number of notes that you write. Now we got that problem group. We got that group where it's a 1-hour group and there's 15 people in it, or that 90-minute group that's got 20 people in it. And I spoke to someone here before, and apparently there's some potential resolution for this. But if you don't have a space, so what happens is when we get bigger, there's a state requirement or a payer requirement that you have to have, what, 1 to 10? 1 to 12, and that's common. But that's per client. It doesn't mean the group can't be bigger. So what we do is we've got co-facilitators, right? So you got 20 people, and you got 2 staff in there because you're not allowed to have 1 staff in there because you need a staff per 12 persons. What would be much better if we didn't have a space problem was divide that group into 2 groups of 10 so that we actually have a group, not a bus trip. And you can do collaborative documentation easy because there's only 10 people. You got a better group because you got a smaller group. And a lot of substance abuse agencies do this. And what they do is they say, the amount of time I'm saving, forget even just splitting up the 2 co-facilitators. If I'm 1 staff and I've got 16 people in an hour group, with the amount of time I'm saving on documentation, I can run 2 groups of 8. They're better groups, they're easy to collaboratively document, and I've got the time now because I'm not spending 4 hours a week sitting in my office writing progress notes. So that's the way, so it's not just a matter of doing it, it's also saying, well, how am I going to reinvest the time I'm saving to provide better clinical care? So substance abuse organizations around the country are jumping on this except where they have space problems. Because I can't run 2 groups if my group rooms are scheduled out for the whole week. I wind up having to run this 1 group of too many people. So I can't answer your space problem, but that becomes a different strategic challenge, right? In other words, to me, that's an easy one. You know, brick and mortar, that stuff, that's not the hard thing with getting people to conceptually buy into this. You know, it takes money, you may or may not be able to do it, but it's a fairly straightforward problem. Do I have space to run 2 groups in time, or I don't? And if I don't, is there a way that we can make that work? But when you get really big groups, like I said, I've worked with people who have 30 people, 25 people in the group, an hour group. I just say don't do collaborative documentation. You just can't do it there. You know, it's just too, you need the whole group just to do the documentation. You're going to get to run the group. Now, if you do curriculum-based groups, you know before you walk in the room what that group intervention is going to be. Right? You know the topic for today is positive integrated thinking and its impact on blah, blah, blah. People make up Word documents that say for session 1, this is the bulk of what I'm going to put there. For session 2, this is the bulk. So they don't even have to take the time to write out that whole thing. They can just plug it in, copy, paste, plug it in, do a brief summary with the folks who have it, and then start this process of going through. Now let's say I only get through 6 of you. You know, it was a little bit of a struggle today. I say, sorry, you know, we didn't have enough time to do your notes with you. Next time we'll start with you. And I'll try to manage my time better. A lot of therapists use like a flag or like a green card you just use in soccer. And when a person gets to 90 seconds, it sort of becomes a joke in the group, like we got to wrap it up. You know, because we want to try to get through to everybody. So you leave the 2 minutes, but you hold them to about 90 seconds or so. And a lot of times it takes them 1 minute. You should just briefly summarize the answer to the questions. You know, it's not a whole lot of complicated questions. So if you're like most organizations, and if you run a lot of groups, it's an awful lot of paperwork generated. To me, a waste of clinical time sitting there repeating that same stuff over and over and writing all of those notes. And again, a lot of the clients didn't say anything, so what are you individualizing? And how are you making that an individual connection? It takes work. So here's an example where we don't want to show the screen to people. There are some organizations that have an LCD projector on their group walls. But they've worked with their EHR to make sure that only first names come up, and that goals and objectives that don't relate to this group can't show up. Because nobody else in the group has a business, and especially in substance abuse, to know your last name, or to know about, you may be here for substance abuse, but you have another goal related to trauma. People have no business knowing about that. Most of us aren't sophisticated enough or want to go through the trouble to do that. So it's the one place where, I've got my table up here, I'm bringing up the notes, and you're not seeing them. What I say is what I say I'm going to write is what I'm going to write. And you can review it any time. But the reason we don't show it to you is because, we don't want to share last names or information that's not appropriate for the whole group. So does that make sense to anybody?
Some groups that, because in peer support, information for non-CPS staff is 1 to 15, but CPS staff is 1 to 30. So if there are 20, 25, and Monday, 30 clients, would it be appropriate to just do the interventions with the group and not do the individual stuff?
Okay, if you really feel that 30 is a good number, my first question is, do you think 30 is a good number to make a difference clinically or help you? So if that's not true, we start to say, okay, we have to live with what we have now. And in terms of living, because the question was, what if for peer support, it's 1 to 30?
For
That category?
CPS staff is 1 to 15. So there's at least 15.
There's at least 15, and a certain staff can be up to 30, you said? Is that with co-facilitators or with one?
CPS is 1
Okay.
to 30.
Okay. So, and I asked the question, does that seem like a reasonable number to potentially have? And it doesn't, and it's not. So the first thing you could do is, what some organizations do is they hand out a form with those questions. They say, what I'd like you to do before you leave is everybody fill out, put your name on it, fill out the answers to those questions, hand them in up here before you leave, and I'm going to incorporate those statements into your record. So the problem is you still got to do 30 separate records. Some organizations actually have a scanning system where they put them in and it becomes a scanned part of the electronic record attached to that note. It's still too many people for me to be sort of an effective group, so what you want to try to figure out is, how long do you think it takes you, and when people always underestimate, it only takes me 5 minutes to write a note. But we've studied this, and it doesn't take you 5 minutes to write a note. By the time you go, sit down, find the note, pull up the document, think about it, write the note. A lot of times it's more like 15 minutes to write a note. For a group, it might be 10. So if you have 30 people in there times 10 minutes, it's a lot of time. And if you're saving that time, you could reinvest it and run 2 groups of, instead of 15, 7 or 8. It's going to be a much better group, also much easier to collaboratively document. And again, the only impediment might be space or schedules. Buses come and bring people. Do we have a way to have them bring people, those practical issues. But another way to do it is to have them fill it out. It lets them have some of their information incorporated. But the problem is you can't really talk to them about it or clarify it, or if you don't understand it, it's not very helpful to do that way. We just did the Advancing Standards of Care with Bipolar Disorder that I mentioned earlier. We had 10 organizations that were using the same, it comes out of Columbia University in New York, Center for Practice Innovations. It's a turnkey, 57-lesson wellness self-management program. And it takes IMR, it converts it to actual handouts, individual worksheets for everyday topics, discussion points, action steps that they take home, and all the materials there, and it's all free. So we train people on how to use that, and then we use the DLA 20 to measure it. And the place it worked best of all was in the peer programs. So the peers loved the material. They used the DLA. They were using collaborative documentation. But we had the same issue initially, where they had co-facilitators of 20 people. And we finally convinced them it might be better to have 2 groups, have each of those facilitators work with 10, and have much more time for discussion, have time to do the individual worksheets, do the collaborative documentation. So it's just a matter of reinvesting the time you save in a good way, which is better clinical service and also easier to do the collaborative documentation.
So if you have 15 people, you're meeting with them,
If you have 15 people, you want an hour and a half group.
and we're running on break, say an hour and a half.
Right. You could. That, to me, it's pushing it. But you have to decide whether or not in an hour and a half you can afford to only actually run the content part for an hour and have this part. It gets kind of long for people to sit and listen. So to break down. But one of my favorite stories is I had an art therapist who I trained up in Oregon. And he, when he asked that question, who hates this already, when I asked that this morning, he had both hands up. He was a young guy. He was an art therapist. He ran a lot of art therapy groups, which I didn't know that much about. We sat during lunch and talked about it. But he said, this doesn't just fit the whole sort of art therapy thing. So, like I said, the intro lunch, he said, listen, I'm going to try it the way you did it. I'm going to do my best. And then I'm going to call you or write to you and let you know how it is. And if I don't like the way it works out, I'm not doing it. So I said, all right, that's all we can ask you to do. And he became a trainer. He breaks it into a description of what we're going to do, doing the activity, and then what he calls sharing space, which is giving people time individually to reflect on. And he said he was learning so much by having people in the art therapy groups individually reflect on what they did that he never heard, had the opportunity to hear before. So he became a real convert for it. And it just saves so much time. It's like a lifesaver if you run a lot of groups.
So I know we talked about this before. I'm confused on the answer. So if we are writing collaboratively with a client, but we also want to write in a manner that satisfies the potential audit, do we use any clinical terminology to illustrate we're using evidence-based practices?
There's no requirement to do that. However, when you're using a tool like the group, you're using something like the Wellness Self-Management Program, which you can just do, because there's a manual, all the lessons are outlined, and what you can say is we use Wellness Self-Management Curriculum Lesson 2. Today we covered Lesson 3. And then the whole rationale for using that and everything is in the manual. The clients will know what it's about. And one tip, if you use those things, is to call it a course. It's a big thing we learned about bipolar group. When we introduced it as a group, we lost a tremendous number of people before they ever started lesson 1. They were recruited, never came to even lesson 1. They said, I don't want to hear other people's problems. I sit around hearing other people's problems, and they said, and it was really social anxiety. They weren't comfortable in the group. But when we called it a course, because it's laid out like a course, it's got chapters and lessons, it's got material, and we said this is a course to help teach people how to manage their illness, much better initial engagement. Because they picture like a college course or a high school course, so they know they don't have to speak up and bare their soul in front of everybody, and they didn't necessarily, it wasn't the social anxiety thing because of that. They weren't going to have to just listen to other people's problems, they were going to learn stuff. So even just little subtle shifts in how it's presented makes a huge difference in the attrition rate or engagement rate. And that's free. It just might be something worth looking at. It's the Center for Practice Innovations at Columbia University. You just put Center for Practice Innovations, okay, but it's Columbia University Department of Psychiatry. And it's in Spanish, it's in English, it's in a couple other languages. It's also wellness self-management too. It includes physical wellness and behavioral health and mental health wellness. Wellness self-management too, a plus rather, incorporates substance abuse issues. So for the dually disordered, it includes those issues through. You don't have to come up and make up your own materials. There's a little video on there how to use it, and you get PDFs free. You can order bound copies, but the idea is that each client gets a workbook that they keep. You may keep it at the center, but they get their workbook back every week. So it's nice that it's free if you want to use the PDF copy.
I had a question. This is kind of more of like a practical question. I was wondering if one of the management might be able to speak to it. With group notes, when you write the master note, are you able to sign that more than a few minutes before the end of the hour? Because I know with individual notes, they don't want you to sign it before the
You can, you cannot, you have to go back and change the time, but what we're doing
Okay.
with the notes, right now the schedule screen is the first one, it's gonna be the last one.
Oh,
And so that's gonna allow you to not have to go back to the front of the note and do all that, and so we think that that will work. That's what they do with Viewpoint, she says it works, we haven't tested it out yet, but we're gonna move that schedule model to the end so that you don't hit that, I can't sign it before the end of the session. Now, it doesn't fix the problem of not being able to start the note before the session. if your 9 o'clock didn't show, you started at 9:45, you gotta go in there and change the start time.
Okay,
So
because
it
I
should
know,
allow you to change the end time.
okay,
I'm
so,
gonna allow you to sign up before the end time.
right, because with group, like, right now, the way it is, like, before the individual notes will pop up, you have to sign a master note, and so that's why I was curious about how that would. Thank
Those are good questions, and the kind of questions that'll mess people up if we don't have a chance to discuss that. Like I said, to me, they're kind of easy answers, but they're critically important.
For the majority of you in the room, Walton County's gonna pull their hair out, because they're gonna pilot it and hold that fixed before it gets to you. But, Walton County might not be so excited about getting it fixed.
Yes.
You addressed like how the nurses notes this process. I mean, I can see it working, I can see doing this for most of the time, but there's sometimes, you know, when I see people for 10 minutes or 13 minutes, that's my session time, so
Right.
does it work with that?
Well, I'll tell you, most, even psychiatrists meet with people for 15 minutes. Okay, that's sort of a 15, some is 23 an hour, a lot of times it's 15 minutes. So what Dr. Kern does, and you have to be very good to be able to do this, and you may not even be allowed to do this here. He develops a more complete note than you would have to once. So he puts in the static information, you know, all of that kind of stuff, the diagnosis, the static stuff. And what he does is he takes that into today, pastes that in, and deletes everything that had to do with updated information. So for one thing it does for him is it gives him a lot of information that he wants at hand with that client. Then, so he calls it, you know, it's paste and replace, so he cuts that out. There's a real danger, we've talked to the federal government about this, about what they call cloning, which is that you're just cloning notes. So the content of his note is always written fresh, it's obviously a different wording based on the conversation, but he's allowed to have the current diagnosis and the current medications and all that there. If something changes, he changes it, then he copies that one forward. So he's not having to rewrite everything about the client, but he immediately erases it. They have to be careful. For example, in his format, he's got a thing that says, is the client currently dangerous, you know, to self or others? And that might be no. But this time he meets with the client and they just got out of the hospital for a suicide attempt. He can't write in the content part that the client just got out of the hospital with a suicide attempt without remembering to change that no to a yes. Right? You can't have one part of the note saying they're not dangerous to self or others and the other saying they just came out of the hospital with a suicide attempt. So the dangers to this is you have to be acute, but he doesn't have to write a whole lot new because he's just focusing on the parts that are different today. But he likes to have a lot of information available to him. He likes to know lab results. He likes the last lab results. He likes to know the diagnosis, you know, the full diagnosis. He likes all of this stuff there. And then he eliminates what he, you know, sort of the interim update and the intervention part and the plan part and does that there. If you're only doing a 10-minute intervention, it's short, but you're probably not going to have another 5 minutes. You don't want to cut that down to 5 minutes and then have, you know, 5 minutes of sitting talking about what you're talking about for 5 minutes. So if you're really having a lot of 10-minute interventions, you're going to have to collaboratively document when you can, when you're doing more extensive sessions, or you can do this cut and replace thing, but you have to be careful with that. So those 10-minute sessions, medication administration kind of sessions, or?
Basically a vital sign, and is medication working, yes or no, side effects.
Okay. So that, and those kinds of sessions are probably would get done, unfortunately, more like what happens at your primary care doctor's office. You would have a template, you take their vitals, you put it in. You know, so you'd kind of be doing it collaboratively and concurrently. It's okay if the client knows what's there, but you would probably just be doing what your primary care doctor does when they see you, is putting things in as they're getting them. We don't have the luxury for this, but because of the pressure and the value of psychiatry, there are some, both in physical medicine and in behavioral health, they hire an assistant to the psychiatrists, and that person's doing the documentation the whole time that doctor's talking. And they're doing that, so the doctors are reviewing it, signing it, but they're not actually doing the documentation. Because they want to be efficient, they want to spend as much time as they can in contact with the client. They have such a short time, and the value is such that, you know, they can get away with it, but most of us can't. Don't have that.
I have a question
question. I know you didn't really want to talk about children that much, but
Sure.
even a little bit. You
I'll
said-
talk about it, you just won't believe me. Questions about children?
So, I was thinking about, I had been running, we do a lot of school-based counseling. So when we're working with children, we're also in the community. So you got
Right.
both sets of things.
So these young children, or the adolescents, both?
Both. So I was running a 45-minute group in a school with 8 first and second grade, first and second graders. And what comes to my mind is, because at that age especially, I'm so active. I don't
Right.
sit down and not with a computer. I'm moving around the whole time. And I like the suggestion but I guess came from the other person about writing things as you go, but I wondered if you had other things, because I don't see those, thinking to my group of them
Right.
sitting through, the last.
So this has to do with combining all the worst possibilities. You've got emotionally disturbed young kids
Yeah.
in a school setting who are running around the room. So at some point you have to draw the line, and say, is this really something that's of value? So first of all, it should be focused. But from what you're describing, I know what you're going to describe as a normal school-based setting. A lot of people's complaints is I'm meeting people in the cafeteria, I'm meeting people in the hallway. One of the things we always say is, you're doing a service to these schools and school districts, and this is a professional business. You would have a doctor going in doing a medical exam in the hallway, that you have to say, we need confidential space to do this. When we come into your school, you don't have to send it out to us, and you really need to negotiate hard with that. But with a group, I don't know that I could give you a good answer. Maybe Catherine can. But for 8 young kids, because I've got grandkids now, so I have my own kids, so I know what 7 and 8 first and second graders can be like. Particularly if they're referred to you for emotional problems, and trying to somehow, like if you think about the checkout process, those other 7 kids aren't going to sit there and listen to what that one is talking about. So my inclination is to say that might be an exception. You also have to worry about the medical necessity and make sure that that group, you believe in your heart of hearts that that group can have an impact on helping those kids reach those goals. And if it does, that's good. And if the collaborative documentation would get in the way, you could make that an exception. Because it's tough, it's in the community, it's young kids, they're emotionally disturbed. But I would ask the question of Catherine, because I think we can hook up a time for Catherine, right?
And I'll say, I used to do collaborative documentation with a group very similar, and of course it was in our building. You would have to take papers that you could stick on the wall, but we wrote in kid language the 2 or 3 goals that they were working on in that group. I'm not going to put other people, I'm not going to spit, whatever their
Right.
goals were. And we would, at the last part of the day, put them on the wall, and all the kids gave feedback. How did Rob do today? Rob didn't hit me. He got mad at me, but he didn't hit me. And so it became
Right.
Rob might drop hits.
Well, those are good. Those are good suggestions, though, for how to make an activity as that will still give you that feedback from every person. So, again, I want to give credibility to that department. I haven't had to hone those skills with my kids. You have my admiration for how you go to a school and run a group for an hour with 8 kids.
Does it count, can we call this concurrent collaborative if you write the group note as a group and then auto-populate and then walk out and do everybody's individual on your own time in this kind of situation where you can't expect them all to sit still? Because when you ask the group, hey, what did we do today?
Right.
And then you all do the group note
You
together.
could do the group part together. If you think there's value in it, then I would do that, certainly. And if you think there's not enough value in doing the individual part with them, although I like this possibility for that, because you could be documenting with it, the kids, you don't necessarily always have to be showing it to them. You're trying to figure out, Catherine does a lot of, not so much in group work, but in family work and individual, letting the kids actually have hands on the computer, especially when they get to be 7 years old and they type better than we do. And lets them actually, she's got all her scales, the smiley face kind of scales there, and she'll let them pick it out and do it. So she ties the whole computer experience in with the age appropriateness of the group. But I just don't know what she would say about this group issue. There's no problem at all with you writing the group part with them and going back, writing the other parts. It would be more efficient if you could figure out a way to do it there, but if it's not clinically beneficial, I wouldn't do anything just for efficiency's sake. if it's just as good clinically and it's efficient, that's a good thing. If it's less good clinically and it's efficient, I'd go with what's best clinically. Any other questions about kids you want to make me not be able to answer?
I guess just one quick one.
Yeah.
When we're talking about younger kids, and again, in the school where we're not always, we don't always have the feedback of a parent
Right.
to enter the part about the goal. I mean, I can ask them, you know, how many times this week or whatever the goal is. Do you have any suggestions, like for those sessions where maybe you don't have that data?
Well, so the one thing that was good that you mentioned, I did mention, is a lot of captains work individually. The current model was to work with the kid and then bring the parents in. And then she would do the collaborative documentation with all of them and have the child actually do a lot of the answering, what did we do today? And that, so that we could sort of reinforce that. If the parent wasn't there, a lot of times the way she'll get the information is to say, what are you going to tell your mom or your grandmother or whoever about what we did when you get home? So she's getting feedback and that response from the child that way. But you're asking a different question about, in the group setting, they're not going to, we can't ask the question, how is this helping you reach your goals? And you don't have to ask that question. You know, I was giving you examples of common questions. So for you to get at that, you have to look at what's required on your note and figure out how you're going to get that information during the time you're there. So like I said, some organizations, you know, focus very specific questions on related to the nature of that group, because that's really what's important for them to get out of the group. And then some of them just have those scales that I don't like in terms of progress, so they'll just type that in themselves with younger kids. So again, there are other folks that work with kids here. A lot of times we get the best answers. So just repeat that specific question. So the specific, say.
I mean, I get really good responsiveness from the kids about what we did today. We can talk about that.
Right.
It's getting the accurate data back to the overall goal. They don't remember how many times this week they were in follow-up.
Right.
Which, so for some notes, it's hard to.
Right. And you don't necessarily, and that's okay. So the question was, you know, she could get good feedback about the group, what they thought about the group, what was important or what was fun, whatever. But they're not going to conceptually be able to put together, how am I doing overall on that measurable objective? And so every single one of your notes, what I look for is relatively periodic attention to whether they're meeting specific goals and objectives. But I'm assuming, are you meeting with these kids, with families also sometimes, or individually sometimes? Or is the only place you're meeting them in school and group? That's not the only place you ever get to meet them, right? Right. So in the group thing, you don't necessarily have to get that precise. As long as when you're meeting with the child and the family, you are getting that precise, or when you're meeting with the child individually. So you could talk more about what they do know about their goals. Like they know they're supposed to be working on not hitting people, or they're supposed to be working on not interrupting, or whatever it is. And at that level, they probably know they're supposed to be better at certain things, but they're not going to, you know, be able to focus on what the individual actual objective is. But we do need to periodically, when we look at your notes, see specific attention, which you might do more with their parents, with them around where they stand now in terms of progress against what you set out to do.
And also with the teachers when we're in the school, so conversations
Right.
with the teachers as well.
Right.
With this, anything that might be a classroom, also like classroom behavior.
Because I'm assuming with young children, you're developing the treatment plan with them and some responsible caretaker, right? So those are the people that are going to know, or we hope will remember more of the details of that. I love it now that we have Catherine, and I can put that, to plan that meeting with her. And she's great. The people, she really has really made a huge impact on child therapists' ability to do this with children, because she did it for so long. Yes?
Is there any way of doing this collaborative group documentation if we don't have access to internet or in the group room?
Well, you know, and that's the way to do it has to be a copy and paste mechanism. So if you don't have access to the internet, you have to come up with like a Word, what we call e-forms, a Word document that's a template for it. You don't have to put in a lot of the start and stop time, because that you're going to do when you do get to your EHR, if you pull up a person's note, you can copy out the group intervention. You don't have to do that once. You would pre-populate everybody else, and then just copy out those individual statements and plop them in.
Unless you're doing this in a room in the courthouse that I have no control over, that's not gonna be an issue. We sent out surveys a couple months ago. We're in the middle of a big refresh. 3 sites have already had it. Walton's next. We're dropping new boxes. We're adding wireless to places. We're bringing in laptops. We're bringing in tablets for community-based folks. So that stuff.
The issue will become less of a problem. Because you do want in your group rooms to have reliable access to your
And we did
EHR.
that. We had your managers survey every site for us, so we know what routine it brings down.
And in the meantime, like I said, what starts to happen is if you do collaborative documentation with people in some settings and not in others, they start to wonder why is that, right? Like why when we're an individual, we do group in this room, we do, but we do group in that room, we don't do. And if what we're telling them is it's important for us to document their feedback and we'll let them know, we have to do it everywhere. So that's where you can use an e-form. I've even seen people say, listen, my computer just blew up. I've got a pad here, I'm going to write down what you say, and that's what's going to show up in your note. And if you want to see it at some point, you can. So the idea is that we want their input, we want their feedback. Sometimes it's going to save us all the time. Sometimes it's going to save us most of the time, and sometimes it's not going to save us much of any time. And we try to make that shrink until it just about goes away with these technology kind of issues. Like I said, a big challenge for a long time was, even in Manhattan, New York City, you can't believe how many dead spots there are there in terms of getting a wireless connection. It's getting much better, but with all the buildings the way they are, people would say, I can't get a connection. Certainly in rural areas, you have trouble. So before we had some of the traveler programs, people just had to assume they were going to have to use the e-form, like a Word document, and when they got back to the office, copy and paste it in. So the content was done, I don't have to think about it, it saves me time, but not as much as if I could do it out there. So now, like I said, the EHRs put these traveler programs in which you can type into what looks like you're typing in the EHR, but it doesn't matter if you're connected. And then when you get back to the office or when you get into a connected area, it'll upload the stuff that you need to the client's files. And that's all in response to people moving to doing this in the field. Other questions? Yes.
Maybe a medical records question, but I foresee that some of my clients will say, okay, can I have a copy of that?
Right.
And the answer is yes. I mean, if they're doing it with you, they have, again, we talked about earlier, if there's an issue with something that we think they shouldn't see, then we're probably not going to be doing that collaboratively, but yes.
So the question there is, a lot of organizations, if you look at your actual policy manual, have a process in place for people who request clinical record information. So before we just say you can hand them the record.
Oh yeah, I'm not going to ask you to print everything off and hand it to them in the session. No, they do need to go through the protocol.
Well, but that's a whole request
Right,
protocol.
it is.
What other organizations say is we've moved to collaborative documentation. They already know it's in the record. Anything you collaboratively documented, you can print right there and give it to them. A lot of organizations now have the client sign the notes too.
And we may want to look at,
So you may want to look
changing
at
it
that.
for the notes, but I don't want y'all to feel like you have to sit there and copy the whole chart for somebody.
Oh, no. Yeah, no, we're talking about just, oh yeah, no, if they want their whole record, yeah.
I mean, if they're writing it with you, there's no.
Yeah. We just don't want people, you talk to your QA person, we don't want people violating their own policy, because at the time the policy was written, nobody was doing collaborative documentation. So it's more gets interpreted in that record access
All our
policy.
policies get rewritten.
But this is right. It's funny, the only place I've heard of that, I worked with an organization again in New York City that dealt strictly with the elderly, they were homebound elderly. And there were actually a lot of folks that were Holocaust survivors. This goes back about 7 years ago. A lot of depression, anxiety, and strictly homebound services. So, again, the staff said these kind of folks aren't going to want to do this. They tried it, and it turned out that they very much liked it, but for some reason that elderly population wanted a copy of everything. It was like, I spent the time writing with you, I want a copy of that. So, and they were mobile, they were out in folks' homes. So it created like a new problem for them, but it was a good problem. One solution was, we have to just charge you on a per page for the copies, and it was like a quarter. The request went away. But then they decided that's not really, people should be able to have it if they want. But they also had a very interesting, I learned a lesson there about objectives too, like I said earlier on. And their favorite objective, because everybody, a lot of depression, and the favorite objective was client will identify a new trigger for the depression every session. So I said, you've seen some of these people for 3 years. They must be up like 300 reasons that no wonder they're depressed. You know, it's the craziest objective I ever heard of. I get depressed if I had 300 reasons to be depressed. So, but it was just easy to do. It was supposedly measurable and all that kind of stuff. But I don't think you'll have too much issue with the people asking for it. Like I said, with crisis services, they're kind of going out of their way now to do that. Because they kind of believe that the person's not going to remember some of what they got said because they were so, they were in crisis. So, and they actually format a different crisis note, recommendations, resources, that kind of stuff. Anyone else? So just let me ask you a question about pilot. How are you going to work that?
So we're gonna be piloting, it starts July 1st, we're gonna be piloting kind of everything on Walton. The open access, the concurrent collaborative documentation, the centralized scheduling. We're gonna create a version, sort of a mock version of that. So we'll do that for the month of July in Walton County. Taryn and I will be there, one of us will be there every day. We've got an intern up front that'll be up there with us every day as well. And so that we can deal with all the snags and, study it and then make changes. And then we'll roll it out to the rest of the agency August 1st.
So what's good to do is, part of the reason I said the pilot is to hear, it does a couple of things. It lets you know internal, maybe documentation formats, EHR problems, office setup problems, so the leadership can support this.
Right.
It also creates some champions internally who, let's say, well, they can do it in the ACT team, I can do it in the ACT team. They can do it in, with kids, I can do it with kids. And so it's good to debrief the pilot staff. The one thing I would warn is that if they're going to pilot it, when you roll it out everywhere else, everyone else wasn't necessarily, at the table or involved. So my suggestion, and let's just ask if there's opposition to if people wanted to be sort of early adopters of this, so they could get their, maybe in writing, an email, a format you could do to let them get their 2 cents in.
Right. I was going to say that to you earlier. You kept saying, pretend as if you're going to start this on Monday.
Right.
Start it on Monday. There's nothing that that keeps you from starting it. We've had some folks who started already, particularly like Michelle's done on our committee. On the current climate documentation's done it. Rico's done it with ACT. So start it on Monday, because yes, then you can give us feedback as well. You're not going to have the newest versions of the notes yet. They're going to be more streamlined, but you're going to get that practice. Your clients are going to get the information. You're going to be able to present it to them in a way that's, so don't feel like you have to wait until it gets
Okay, so that was really my question, because you don't really have credibility to make suggestions or ask for changes if you haven't tried it.
Right.
So if you're doing it for a month and you say, okay, based on the folks I do with it, here's what's happened to me, here's what's worked well, here's what hasn't, you have credibility to do that. So I'm just going to ask you a question, and again, nobody's taking names here today, but based on today at this point, how many people feel that they might like to, try this, try the process? Okay, good. Good. So you got enough folks spread around enough programs to try the process. And my advice would be for some folks will say, well, I'm going to wait until the EHR system is perfect. I'm going to wait till they change the forms, and I'm going to wait till the sun shines every day and all that kind of stuff. And it holds things back, and it really stalls progress in terms of the value of it is people using it so they can help make those corrections instead of waiting till everything's done. So I just want to show you another, this one isn't a foreign film. It's a very brief film. Let's see if we get it to work before I do. Oh, man. I'm looking at the screen. Oh, I can't. Okay. What is that? Because you have two screens. that I guarantee you that you can do this well enough with the system you have now, the formats you have now, the clients you have now, to really make a big difference now. And things will get better, things will get changed to help support the process. But don't wait till it gets done before you start to do it. Yes, sir.
Yeah, earlier in the lady back here mentioned problems in the field. Could you address some of those problems?
Oh, yeah, I'm sorry. Sometimes we spend a lot of time on this. I don't know how much field. We talked about it a little bit. What it comes down to is also the nature of work we do. Now, do you guys get paid, like, you want to transfer a person to a physician's office? You're going to transport a person to go shopping. Do you get paid to just take them shopping or take them to the physician's office, or you need to be teaching them skills? You need to be helping prepare them for the questions they're going to ask the physician, maybe help explain what the physician said, right? It's got to be an intervention. So that's good. So now it all comes to physically, where do I do it, right? So I have people that say, well, I meet some of my people in NAC teams in McDonald's, or I meet them at the library. Well, again, if it's a confidential enough place for you to have a discussion with your client, it's a confidential enough place to sit at the computer and summarize that. Because otherwise we shouldn't have had the discussion there to begin with, right? So there's technical problems like, even if you are going back to a person's home, if it's like most places, the first challenge is, where's a non-yucky place for me to lay my computer down? Or to sit where I can do this with them. So usually we move to kitchen areas, to solid surfaces. We do it in cars. And it depends on the environments, obviously. Some people keep their apartments extraordinarily neat, and other people don't. A lot of people that drive people to, like, for example, physician's office or things like that, when they get back to where they're going to drop the person off, they do it right there in the car. They just find, it goes sort of like this. Is this a worthwhile thing for people to start getting it and understanding what we're doing and remembering what we're doing? If we say that so, we just need to be creative about where's the best point for us to sit down and summarize this with the person. I'm trying to think, other than connectivity, which we talked about, what I would do is have, Word forms or what we call e-forms on your computer. So if you're not connected, don't worry about it. Type it in, copy and paste it later. School-based services, I talked about a big argument, a big move now is that we go out, we go to them, and they're not giving us adequate space. We're sitting at the end of the cafeteria table while kids are at the other end trying to do work. Other professionals wouldn't do that, so we don't always feel that we have to do that. Can you give me some other specific examples of where it would be a challenge for you? And there are plenty of good examples. Excuse me?
Probation.
Probation, okay. So you're taking them to the Division of Probation to do like what? Okay, make sure they understand the instructions and you maybe contribute to report. Now, are you meeting them there or are you driving them there? Excuse me? Taking them there. And then you take them back? So that's where you could do that. Okay? Also, we get stuck waiting a lot with this, sometimes. So sometimes those waiting opportunities are good places to do it. But if the last place that you were, you're going to now be taking the client home. A lot of people have chosen to do it in the car as opposed to going back up into the apartment or the residence, just because it saves more time. They've got other appointments to make, and it's quiet, it's isolated, and so they just literally work out. Some of them say the way that my car is, I can't do it there. So they wind up sitting in the back seat, clients in the front, or vice versa. They're turning and going over it with them. It's a nice day like today, they're going out with the computer on the hood of the car. Or if that's not appropriate, they will go up to the apartment and do it. Will you hit 100%? Maybe not. But I think what you'll find is the benefits are such that you'll get very creative about where's the best place for this particular client, their living situation, the kinds of things I take them to do. I think it's real important to, because I read a lot of notes that sound an awful lot like me, like I took the person shopping, and yet it's attached to the goal that says we're teaching folks how to select meals within their budget that are healthy and so forth. But they've been doing that goal for like 3 years. That throws a big target on your back. People can't learn how to shop for meals in 3 years They're probably not going to. And what happens is, what we're really doing is trying to help people out because they have nobody else to take them shopping. And that makes it hard for you to document because you're going to document in one way, but what really happened is you took them shopping and said how much money you got and that kind of thing. And that's where we start to move from accidental fraud, like I just didn't know how to document properly, into the intentional fraud arena. Because the question we ask ourselves is, we won't do it for these clients, who will? And I agree with that. But you can ask yourself the question, if this person had a friendly neighbor who was willing to take them shopping, would you be doing it? If the answer is no, it means we're not really doing skills training, we're taking them shopping. And if we do a lot of that, it throws a big target around our back around whether that's a medically necessary service. And I'm not saying you're doing that, but it's a lot easier to dock with the person, and there's more benefit in documenting with the person if you were really working on training them skills. Does that make sense? I'm going to sit here, we're going to talk about what we did, let's review, do you remember what we said to do you remember how much it cost, you know, that kind of thing. Because the focus is now on skill training. So many case managers get stuck because there's an expectation that they're going to do for people, and there's no one else to do it. The problem is, if Medicaid comes in, that's just not their business or their question. You know, it's we pay you to do skills training, or to advocate for a person at the probation department. You know, some active sort of thing that we do. So I think it's the most difficult of the places to do collaborative documentation is with ACT teams because of the nature of the clients. They're so disenfranchised and the places we go. But I think those are the people that can sometimes benefit most because they feel like people are just coming out visiting them and taking them place and they're counting on that. And they're not focusing on this as being part of a way to learn skills and self-management skills and all of that. And I think the documentation can help with that. You know, it doesn't mean it's easy. On the other hand, if you learn to do it, you don't need to find time to write all those notes and remember to do all of that. And particularly if we're moving to same-day documentation standard, which we're moving to, how do you get that done today? You know, it becomes, how do I do that? But that is, it is the toughest place to do it. You know, you need the equipment, and I know there's a commitment on the part of the leadership to get equipment into folks' hands and to streamline the documentation and make it easier for everyone. Any additional questions? Okay, well, you've been a great group. I really appreciate it. I appreciate you having me here. And I'm going to be up here for a while like that all the time.